Welcome back to another episode of EM Board Bombs. Hey, Briggs, what's up?
Happy to be here.
Happy to be here. As am I. As am I. Hey, we're going under the covers of EM Board Bombs here. How are we going under the covers? We're gonna do a mashup episode here. It's a mashup of an ideology that I don't want to say freaks people out, but everyone just gets confused about. It's related to dermatology. That's number one, right? Boards love to ask this question, and just clinically too. Anytime you see this, it's one of those that people are always looking up. They're like, I need to find this somewhere. And they're going to their go-to
Right.
reference to figure out how to differentiate this particular skin condition in peds.
And you can't just say it's maculopapular.
No, yeah, you can't just say urticaria or contact dermatitis. This is not one of
Follow
those.
up in a few days.
Right? Yeah, follow up in a few days, follow up with dermatology. This is one of the ones that you actually have to figure out, do I give steroids? Do I not give steroids?
Exactly.
Do I need to admit this patient? Do I not need to admit this patient? Does this patient need to get antibiotics? It's one of those. And we're going to differentiate them and make them a lot easier here. And we're going to take you under the covers because this is actually a part of EM Rapid Bombs. So our EM Rapid Bombs podcast, as people know, the premium pod, that's the one where we drop 4 to 5 minute long episodes. We've got almost 400 episodes. We actually took 3 of those questions and we're going to mash it up so you guys can get an idea of what EM Rapid Bombs is like. And so the general public can be let under the covers, under the hood, as we should say, of EM Rapid Bombs.
For sure.
I guess under the hood, is that even appropriate anymore, Dr. Briggs? Because I guess EVs these days don't have anything under the hood.
Under the frunk.
Under the frunk. There you go. All right, we're going to go under the frunk here.
We're environmentally conscious as a podcast.
I guess. Yeah, we did not use our carbon footprint was very small in making this podcast.
This is a carbon microphone.
Yeah, and I totally made up what I said, and I don't know if what Blake said is appropriate or correct at all. So,
It's not.
Hey, let's get into it. So, a 5-year-old girl is brought to the emergency department by her parents. She has a fever of 38.6 degrees Celsius. So, what is that, Briggs? 101.5. Okay. And she appears ill. Her parents report that she's been increasingly irritable over the past 24 hours and developed a rash that started on her face and rapidly spread to her trunk and extremities. On physical exam, the rash is erythematous and tender, and there is flaccid blistering with desquamation. A Nikolsky sign is elicited on gentle lateral pressure of the skin. The following features differentiate toxic epidermal necrolysis, I can never pronounce this, from staphylococcal scalding skin syndrome, SSS.
S.
S.
You forgot an S.
And so remember, these are the following features that differentiate 10 from SSS. Except A, is it age of patient? Is it B, presence of mucosal involvement? Is it C, systemic toxicity? Or is it D, distribution of the rash? And lastly, is it E, histological finding? This is a tough one. I love to ask my residents this particular question. It's not an easy one. What is it, Dr. Briggs?
I'm sure they enjoy you pronouncing it too.
The correct answer is 10. I don't even try to say it. I just say 10.
The correct answer here is going to be choice C, systemic toxicity.
Yeah.
That is going to be the exception here. So remember, we were asking the following features differentiating toxic epidermal necrolysis from staphylococcal scalded skin syndrome. And that was C, systemic toxicity. So we're talking about these 2 big conditions here, and they can look very similar in the pediatric population. Both are severe skin conditions. They both present with widespread erythema, blistering, desquamation. I love that word. Love saying that word too, desquamation. However, there are several distinguishing features here. So when we're talking about the age of the patient, the staphylococcal scalded skin syndrome is more common in children, almost exclusively on the boards. Right. You will never have an adult on the boards with scalded skin syndrome. It's always in kids. especially in kids younger than 5 years old. While toxic epidermal necrolysis is, of course, more common in adults, right? Allergic skin reactions in general are more common in adults. I'm talking
Yep.
about serious drug reactions, of course. Allergic reactions, yeah, they're common in kids, but we're talking about, Stevens-Johnson, 10, that those two are classically always going to be in an adult on the test question. So alone, just on the test question, age will get you this answer, I
Right.
think, because the
Right.
test will never throw you a loop of a child less than 5 having toxic epidermal
Nope.
necrolysis. So there you go, done. So this is due to this, immature renal function of children, which reduces their ability to clear toxins produced by Staphylococcus aureus, the bacteria which is obviously responsible for staphylococcal scalded skin syndrome, which is why it's more common in kids. Now, choice B was talking about the presence of mucosal involvement. Now, this is a big deal because this comes up a lot when you're talking about drug reactions
Mm-hmm.
and other blistering skin conditions. Now, mucosal involvement is common in toxic epidermal necrolysis, but it's typically absent in staphylococcal scalded skin syndrome, hence the word scalded skin syndrome. You're not going to have any mucosal involvement. So patients with TEN can have severe mucositis. It's pretty bad. It can
Mm-hmm.
affect the eyes, the oral
Yep.
cavity, genitalia. It's pretty awful stuff, while scalded skin does not cause that. Why don't you get into these last two answer choices here, the distribution of rash, the
Right.
histological findings, and then, of course, our the correct answer here, which was systemic toxicity.
Sure. Let's get into the incorrect ones first. So distribution
Yeah,
of
of
the
course.
rash. So the rash in SSSS, it often starts in the face and then spreads to the trunk and extremities. In 10, the rash starts anywhere on the body. And that's why
It
we
does
set up
whatever
the
it
question
wants.
the way we did. It's sort of what?
It does whatever it wants.
Oh, it just does what it
Yeah.
wants. Exactly. I just reminded me of that South Park episode, Carmen's being like, I do it all. But anyways, and then E, histological findings. In SSSS, the epidermal splitting occurs in the granular layer of the epidermis, while in 10, the split is much deeper in the epidermal junction. For some reason, they love the histological stuff on like 10 and SSSS. That's why we mention it here. Ideally, we would not like to mention that.
No.
But again, we mention it
My
because
least
we
favorite
have
class
to
in
here.
med school. Least
I
favorite
know.
class in med school.
I know.
I like most of them. I like most of them. That was the one I did not like the most.
Didn't you have a book on histology that you published?
No,
Or is this pathology?
it's pathophysiology.
Pathophysiology. Sorry.
Yeah, it's available on Amazon still, by the way. Soft plug.
My gosh. Yeah. Link in the bio. No.
Yeah, if you're listening to this podcast but still want to pass step one,
Right. All right. To the correct answer was systemic toxicity. Both conditions can be associated with systemic toxicity, such as fever and malaise. Now, this is due to the extensive skin damage and potential for secondary infection. So, therefore, the presence of systemic toxicity does not differentiate SSSS from 10. Right? But the things that are going to help you differentiate are going to be what? All right. Hey, I'm going to do a quick. Can I do a quick?
yeah, do it.
What am I going to do here?
The viewers are real. The viewers love it.
The viewers love it. They love the shorts. Actually, Briggs, I'm going to have you do it. You do the short this time.
Yeah.
Go.
So the following features differentiate toxic epidermal necrolysis from staphylococcal scalded skin syndrome. That's going to be the age of the patient, the presence of mucosal involvement, distribution of the rash, and histological findings. That's what you're going to be tested on. So why don't we bring this in to do some coaching really fast and wrap this up? That's what we do in our rapid bombs.
Do it.
So staph scalded skin syndrome and toxic epidermal necrolysis, they're really scary skin conditions.
Right.
They're going to be differentiated by the age, like we talked about, right? Staph scalded skin is going to be much more common in children, almost exclusively in kids on the test.
Oh, yeah. Right.
TEN is going to be exclusively in adults on the test.
Right.
TEN almost exclusively will have mucosal involvement. Staph scalded skin never has mucosal involvement. The distribution of the rash here, remember that staph scalded skin can start in the face, spread to the trunk typically.
Right.
TEN does whatever it wants. It'll start wherever it wants. It'll go everywhere.
Yep.
And of course, the histological findings really random, really annoying. Staph scalded skin starts in this granular layer of the epidermis. It's just in the epidermis, right? It's a desquamating rash. TEN goes much deeper. It's dermal, epidermal junction. Very scary stuff here. And that's really it.
And that's it. And those are like the four things that are going to help differentiate. The one kind of common feature that you're looking at that we described is that systemic toxicity for both, right? All right. Hey, let's move on. We're going to move on to that next question here.
Let's do it.
So it's the next question of one of our rapid bombs. Again, this is an undercover peek as to what our rapid bombs podcast looks like. These are questions we've literally gotten from that podcast that we have. Again, almost 400 episodes there. A 4-year-old child presents to the emergency department with fever, irritability, and widespread skin erythema, followed by the formation of fluid-filled blisters that rupture easily. The diagnosis of staphylococcal scalding skin syndrome is made. Which of the following treatment options is not appropriate for this patient? It's the dreaded not. Is it A, aggressive IV fluid resuscitation, B, intravenous dicloxacillin, C, topical wound care similar to thermal burns, or D, IV corticosteroids? Briggs, what's the correct answer here?
Correct answer is going to be choice D, IV corticosteroids. So again, we're talking about staphylococcal scalded skin syndrome. We've had a couple episodes on these in this condition here. It's a severe skin infection. It's caused by, wow, I wonder what, Staphylococcus aureus, which releases toxins that cause the skin to blister and peel. Now, what we've talked about previously is that this happens almost exclusively in kids.
Right.
I'm sure there's cases in adults. Doesn't really matter though. It's almost always going to be in kids. And on the test, for your knowledge, it's 100% in kids on the boards.
And for kids, we're talking about less than 6. Briggs,
absolutely.
Right. We're not talking about, they're not going to present a 10-year-old. It's going to be less than 6.
No. Going to be less than 6. And the big deal here is you want to start treating with antibiotics early. So going into these answer choices here, everything sounded really good up until choice D, which was IV corticosteroids. So you're going to give IV fluids. That's great. These kids often have severe dehydration due to that desquamating skin loss from their rash. You're going to give IV antibiotics. Dicloxacillin is suitable. It's penicillinase resistant, anti-staphylococcal. Now, other choices, of course, that are suitable that, a lot of people don't give dicloxacillin really anymore. I feel like, ceftazoline will be okay in some cases, nafcillin. And if you're concerned for MRSA, let's say they've had this before, or there's a MRSA exposure, Bactrim or vancomycin is a reasonable choice, or honestly, doxycycline too in some kids.
And on the test, Briggs, they're not going to give you different antibiotic choices for this one. It's mainly going to be recognizing antibiotics need to be given.
Right. Absolutely. Yeah. So Bactrim and vancomycin will be the big things here. Now, topical wound care, straightforward stuff here. You're going to treat these like thermal burns. Similar management, preventing infection, promoting healing. Lotions are important here, Baxitracin and that sort of thing. That's going to be the same exact management as we do for a lot of our burn patients. Now, the reason steroids are wrong here is because...
Wait, so steroids are not indicated in every skin condition? Hold on.
Exactly. I am steroid injections.
I should pull like a lever here. That's it. Put on the brakes.
Pull the brakes. Get like a cartoon animation for our brake stopping.
Yeah. Skin condition presenting
Looney Tunes thing. Yeah. The reason steroids aren't helpful here is because it doesn't make any sense. You're treating an infection in this case for the skin. The steroids really have absolutely no evidence supporting the use in this condition. They can actually worsen the systemic infection. So think twice before doing this.
Do it.
I would never think about doing steroids before or after this question. So anyway, steroids can suppress the immune system. They worsen the underlying staph infection. In general, if you have a skin infection, don't give steroids.
Hey, I'm going to make another short here for our YouTube channel. All right. So
let's be really short. Don't give steroids.
This is going to be super short, right? So the appropriate management for staphylococcal scalding skin syndrome in children, again, almost always exclusively presenting below age 6, is aggressive IV fluid resuscitation. Remember, there's going to be significant, fluid loss. It's going to be IV antibiotics that are anti-staphylococcal, obviously, and then topical wound care that's similar to thermal burn management. That's the last little thing here that we want to say. Systemic corticosteroids are not recommended for treating this condition, as there's no evidence they work, and they could lead to worse outcomes. Done. Now you know how to treat SSSS.
You got all of them.
I got all of them.
Next question.
SSS. I don't want to add the other one on, Briggs.
Next one.
Hey, this is the last one. So again, after this question, you're going to know 10 and SSSS, like the back of your hand. You're going to know every single way they're going to ask for it. You're going to be able to knock this one out of the park. Again, this is a sneak peek into EM Rapid Bombs and what that podcast looks like. It's rapid hits just like this. We go through question answers and we have coaching, coaching aspects of it as well. You also get emails from our social team with spaced learning that helps you, just remember and retain all that knowledge and content. Again, great for sure, boards, but also for EM Life. Almost 80% of our folks keep using the podcast year after year, even after they're done with the boards, which has been pretty awesome, Briggs, because we drop new episodes every week. All right, next question. A 2-year-old child presents to the emergency department with a 2-day history of fever and diffuse erythema. The child has developed flaccid bullae in flexural areas, and the Nikolsky sign is positive. The most likely diagnosis here is A, toxic epidermal necrolysis, also known as TEN, B, Kawasaki disease, C, staphylococcal scalding skin syndrome, or D, scarlet fever. What's the correct answer, Briggs?
Correct answer here is going to be, wow, gee, I wonder, staphylococcal scalded skin syndrome.
We hope you had it by now.
Hard.
This is one of those come on, retain that knowledge, right?
Exactly. So this is an exotoxin condition, meaning that staph produces this exotoxin. It's going to exclusively occur in kids less than 6, as we've said in previous episodes, because the majority of patients are less than 2 years of age, and this has something to do with their renal clearance of this exotoxin, which makes it just more deadly in terms of causing desquamating severe rash. But otherwise, it's always going to be in kids on the boards. So just keep that in mind.
Always. Yeah.
Now, let's get into some of these answer choices here, because this is a really good differential question. And the boards will do this sometimes where they'll give you an obvious, question stem saying, hey, here's a general picture of something with, somebody with a condition. And there's going to be one feature in that question that will make one condition stand out from the others. Mm-hmm. Because some of these share features with the other conditions. They overlap somewhat in terms of skin findings, right? So the boards are testing you how in-depth your knowledge is regarding these skin conditions.
And we're going to, and just to be clear, Briggs, in the next literally 2 minutes, we'll actually get through 4 skin conditions and the key ways that you'll be asked, about the boards.
Yeah, absolutely. So choice A is going to be toxic epidermal necrolysis, or TEN, and it presents with diffuse erythema and bullae, as they say. And the TEN can overlap and get confusing with staph scalded skin syndrome, but there are a few distinguishing features here that are really important to note. One, of course, is the age. TEN is more common in adults. The second is the mucosal involvement. The TEN typically always has mucosal involvement, while staph scalded skin never does. And they're going to mention this on the boards. They're going to tell you that's going on, that, hey, you look in their mouth and you see something, or hey, you look at their genitalia, or you look in their eyes. That's a big feature. Your eyes are really big here also for Kawasaki's, we'll talk about in a second. So further, TEN is not associated with infection. It's, of course, due to medications, which is why kids are just less likely, because kids are not on a lot of medications, hopefully. Anticonvulsants are the classic offenders, antibiotics like sulfa drugs, penicillins, and, of course, NSAIDs even, like ibuprofen and naproxen. All those, again, adults. We think adults, because they're on medications more commonly, and it's just more common in adults in general. Right. Cool. So choice B was Kawasaki's. Now, Kawasaki's is such a great board question. Such a great board question diagnosis. We have a handout on our website that covers Kawasaki in depth. You don't even have to read that to get the details. We have several premium Rapid Bomb episodes on Kawasaki's that we launched about a year ago or so, and it covers pretty much everything you need to know about Kawasaki just to get it right on the test, because it's such a rare condition that you probably won't see it. Most EM doctors don't regularly see kids anyway, and so it's really important for you to know that feature for your boards. Now, Kawasaki is a vasculitis condition. It's autoimmune. It's not an infection. And it affects some arterial stuff in kids. I love that I'm saying this is an emergency doctor. Some artery stuff.
Hey, this is Blue Collar Podcast, Briggs.
It's Blue Collar Podcast.
All right, everyone knows that if they want the in-depth, 2-hour dives on Kawasaki,
we're not doing that.
There are a lot nicer podcasts you can go to. They're fantastic EM podcasts that you can go to for that.
Some better than others. All right, so it presents with this, of course, a fever and a rash. And the big feature here that the boards are almost going to have to give you is conjunctivitis. They have to tell you about the eye finding. The eye finding in lymphadenopathy is so classic in Kawasaki's. They're going to have to mention it. Again, children less than 5 in this case. Again, this is not an adult condition. This is not an older child condition. This is young children, toddler age, less than that typically. And it's going to be conjunctivitis, fever, and rash. And it involves those hands and feet, right? One of those classic rashes that does involve the palms and soles.
Yeah, like if you're talking,
go ahead.
Yeah, if you're talking to an ID doc about this, and the first question they're going to ask you is going to be like age. 2 is probably going to be conjunctivitis. That's,
Yes, exactly.
you know,
This condition basically does not have flaccid bullae or a positive Nikolsky sign. So that's why it was wrong. And the
right,
question mentioned Nikolsky sign. Now, choice D was scarlet fever. Now, scarlet fever, I feel like younger learners confuse scarlet fever and staph scalded skin syndrome just because they're both
right.
infection and skin conditions. They both are caused
Hmm.
by bacteria that start with S, and they're
Right.
both always like S name conditions.
Yeah.
So scarlet fever is strep.
Right.
Staph scalded skin is, you guessed it, staph.
Hmm.
So scarlet fever is going to be a group A streptococcus infection. Presents with fever, sore throat. Essentially, it's basically like strep pharyngitis that involves skin findings,
Right.
essentially, to really simplify it. And it causes what they call a sandpaper rash. Basically, it's just a red erythematous rash.
They
There's
love
no
using that
flaccid
word.
bullae.
They
Hmm?
love the word sandpaper
No, they love it.
rash.
Yeah.
You know.
There's no flaccid bullae. There's no Nikolsky sign. This is a pretty actually benign appearing condition that
Right.
you treat just the same as,
Right.
strep pharyngitis. You give them
Right.
antibiotics and you treat it and take care of it.
All right, Briggs. It sounds like it's time for that quick summary again. EM rapid bombs. It's quick hitting. Bring it in for a quick YouTube short.
For sure. So staph scalded skin syndrome, it's caused by this toxin producing Staphylococcus aureus. It presents with fever. It's going to be diffuse erythema. It's going to be a desquamating rash with flaccid bullae. And they're going to be mostly in the flexural areas of a child. Yeah, flexural. And it's going to be a positive Nikolsky sign, just like TEN and Stevens-Johnson. The presentation, however, is exclusively in kids, less than 6 years old, majority below age 2. There are some adults that can get this. You'll never be tested on that. It'll never be on the test question. And the key features that distinguish staph scalded skin from other conditions, especially TEN, is because it's in kids exclusively, not adults. There's no mucosal involvement ever, and it's not anything to do with the reaction to new medications.
Mm.
That's really it.
Done. It's a quick
Easy.
short. I love it. Look at that. We went through 3 questions, talked about at least 5 different skin conditions, and especially the overlap that happens between some of them. Mentioned the distinguishing factors, how they are treated, what not to give for some of them, and every machination that you would be asked on the boards for the ones that we mentioned. It's
I
pretty
haven't, I
sweet.
haven't even finished my coffee yet. That's how quick we were.
That's how quick we were. I know. Hey, I haven't either. I'm still working on mine. That's great. Hey, so as always, in the show notes, you can see the link for EM Rapid Bombs. We'll have a sign up from our website. The nice thing is that our sign up now is located directly on the EM Rapid Bombs website. So you'll see that in our show notes. Go to that link, check it out. We have almost 400 episodes. We drop multiple episodes a week. We have spaced learning emails that go out about 3 times a week that our social team does, which is pretty awesome. We also have a private YouTube feed for our subscribers. So you'll get certain episodes with links to just exclusive YouTube videos that are only available for subscribers. This is great, especially if you're studying for boards right now. And honestly, it's great for EM Life because, again, about 80% of our folks, they continue signing up for multiple years. I mean, we have some folks using this for about 3 years now, still listening and still kind of keeping up to date. Because in EM, as we all know, it takes a couple of years to really feel extremely comfortable, especially when you're fresh out. But the cool thing is that we actually have folks. We had a recent subscriber who I think has a son who's EM or IM. They were just mentioning some of the overlap, but they're a seasoned EM doc who uses it, and several other seasoned EM docs that love using the pod to kind of keep up to date and refresh some of their own knowledge as well. So that's pretty
Absolutely.
sweet. Yeah. So, hey, Briggs, anything else?
That's all.
That's it. Yeah, we've got the new YouTube channel, and you can subscribe in the show notes. All right. Thanks, guys.
See you next time.
Bye.